Welcome, Dr. Venkata Rathnam Peram.
Thank you, sir.
You learn from him, he is the most experienced and highly...
No, sir. Before we are all kids, sir. We are all kids before you, our experience. So I thank profusely the AIOS organizing committee of APSOS and dignitaries sitting on the dais and my dear friends. So, this is not the presentation. No, it is not here.
So what's it, sir?
It is pasted already.
Just give it there, sir.
No, here only. I gave it to you.
Okay.
Thank you. So we all concentrate, once it is a glaucoma, we all concentrate from the our main post-graduation itself. We think about only intraocular pressure is glaucoma. Glaucoma is intraocular pressure, that's all. Beyond that, we don't think anything else. Now, this is our understanding. Intraocular pressure, nothing but, glaucoma is nothing but intraocular pressure. And another is, now our thought process is changing to intraocular pressure to optic nerve sensitivity and optic nerve ischemia. Now the present day, the major thought process is going towards the optic nerve ischemia and intraocular pressure as well as optic nerve sensitivity. In spite of knowing all these things, we have certain gray area there. This gray area is persisting since a very long time. Till now, we are not able to crack into that gray area to find out what is the pathology of glaucoma. Now, this is the reason why we want to see what else can cause glaucoma, what else can contribute for the loss. That is the reason why we are going for this presentation. This is the load. Even till today, even in the Monday OPDs in Sarojini Devi Hospital, it is overcrowded. The everlasting increase in the glaucoma prevalence in the society. Right. Intraocular pressure is undoubtedly modifiable risk factor. Still, we have certain other goals when we are approaching a patient. Protect, restoration is, I don't know, it is a questionable. Reduction of intraocular pressure is the main aim. And monitor the rate of glaucoma progression. As already ERDs are told us how to see that and determine the other risk factors what are contributing for the glaucomatous loss. This is the one landmark study saying us that 28% of the patients, it has seen in 167 patients in a multicenter study, saying that 28% of the patients progressed further in spite of being intraocular pressure is maintained at 17. 43% progressed when the pressure is 18 and 19. When 70% of the people are progressed when IOP is maintained at 20. That means intraocular pressure is not always contributing for the total inhibition of the ganglion cell loss. So, though the intraocular pressure is very important, we should concentrate and see other things where the patient is progressing beyond the intraocular pressure. We know the landmark studies about OATS and EMGT, AGIS and corroborative normal tension glaucoma studies. All this says that low perfusion is a significantly a risk factor. At the same time, age is very much significant risk factor. We know that the population percentage of people who are crossing more than 60, it increases, automatically prevalence of glaucoma increases. There is no doubt about it. CCT is another contributory risk factor, and CD ratio, we are giving more importance to the CD ratios, but it is very less. And PSD is also, we are giving importance, but it is also contributing very lesser. And hemorrhage and the disc hemorrhages are very significant risk factor for the glaucoma progress as well as for the diagnosis. So corneal thickness we know all, because the higher thickness will overestimate the intraocular pressure and lower thickness will underestimate the intraocular pressure. We should not get biased by that. The risk is misread by the eye pressure. suppose you see only intraocular pressure basing on to diagnose the glaucoma, if the thick cornea and if the thin cornea, it is very dangerous. Suppose the intraocular pressure is low when you are recording in a thin cornea, but the original intraocular pressure is more. So that is very dangerous to the patient's progression. And thick cornea is otherwise a safe area. Suppose if there is a thick cornea and you are measuring high, and actually there is no glaucoma, unless you check for the intraocular, check for the central corneal thickness. This is the nomogram we are all following, like Ehler's formula. 70 microns change in the baseline are the mean CCT from 555, and 70 microns will change 5 millimeters of GAT intraocular pressure. So either side, this side or that side. If it is less, we need to add. If it is more, we need to subtract. And another important risk factor is DOPP, diastolic ocular perfusion pressure. We don't care about it usually in the clinical scenarios, but it is very important. Once the diastolic blood pressure is 80, minus 16, what is the Gaussian mean of the intraocular pressure? You remove it, it will come around 64. If this reading comes down to the less than 55, it is a very important progressive indicator for the glaucoma. Evaluating the CD ratio, we are all give more importance to this. The single, if you take only CD ratios as it is, unless we are comparing with the overall disc size, then we are making a mistake. There is no doubt about it. Because the bigger disc will have a big cup, the smaller disc will have a smaller cup. So, whenever you are seeing a big cup with a big disc in a big cup, we need to think and compare with it to the disc size, location of the disc thinning, changes in the vasculature, and color changes are very important. We ignore it. Usually, a sectorial color change is significant for the glaucoma diagnosis. Please remember this. Disc hemorrhages are very significant. Disc hemorrhages in a patient with glaucoma are most frequently observed inferiorly, along with PPCRA and nerve fiber layer defects and field change correspondingly. So, it is also very important, and optic nerve head observation for the presence of the disc hemorrhage is an important biomarker for the glaucoma damage. So, myopia, we know this is myopia, as already sir told it, this myopia will always confuse, and Vasanta madam already told that treating the morning glory syndrome, thinking that it is glaucoma. I have seen several cases like that, treating unnecessarily. This requires only longitudinal observation. You cannot decide with a single examination with the myopia and glaucoma. This is very confusing. Unless you follow the case further and document it properly, then at one point you know that this is only pure myopia or glaucoma. Otherwise, you can't decide on the single examination. So, cerebrospinal fluid pressure, of course, reading is very difficult, and modifiability is a questionability. That you have patients with open angle glaucoma and normal tension glaucoma have a lower CSF pressure, whereas patients with OHT have a higher CSF pressure than controls. So, CSF pressure is also important. The damage occurs at the level of the lamina cribrosa. We are treating we are measuring the transcorneal intraocular pressure only, because the movement of the lamina cribrosa, because of the variation in the pressure gradient between the intraocular and the cerebrospinal fluid, will make the damage. And obstructive sleep apnea. We are all forget this. Obstructive sleep apnea is a major risk factor for the developing of glaucoma. Studies show that strong association between the obstructive sleep apnea and glaucoma. Complete ophthalmic evaluation should be advised to every follow-up for these patients. Glaucoma patients with obesity and progressive visual field damage, even under the low eye pressure, should be evaluated for the obstructive sleep apnea, and because the sleep labs are available in Hyderabad. 10% of the obstructive sleep apnea sufferers have glaucoma. No doubt, 50% of the normal pressure glaucoma patients will have obstructive sleep apneas. So, corneal biomechanics are another important risk factor. This evidence suggests that eyes with a thin, stiff corneas are higher risk of developing glaucoma. Though the ocular response analyzer we are not using at all to measure the corneal pliability of these, and in the future I think that it will come into the protocol in the evaluation of the glaucoma. Right. Other confusing conditions with normal intraocular pressure is, so though it is, sir?
Time.
Yes, sir, finishing. Other things are important is multiple sclerosis, Parkinsonism, Alzheimer's disease. We are all forget about this. And toxic amblyophias like tobacco, ethyl alcohol, thiamine deficiency, ethambutol, drugs. There are several other drugs, but ethambutol and INH are important. Vascular, AION and PAON, these are all confused the glaucoma. They are all looks like glaucoma, but it is not glaucoma because we need to think about all these things. At the end, glaucoma is perhaps more multifaceted than the less understood than all other eye conditions, given the ocular, vascular and neurological involvement. Much confusion stems from the glaucoma being a neurodegenerative disease now. Having vascular etiology, yet only IOP being commonly discussed and treated. One final caution is, any patient you are seeing with the progression of glaucoma and intraocular pressure is maintained always and diurnal normal. Never think that all these factors which may be contributing for the loss of ganglion cell. Thank you, sir.